Gagandeep and today we'll be discussing on management of physically disabled children. We'll be dealing this under following headings, that is introduction, definitions, special dental operatory, patient positions, immobilization aids, the changing trends in dentistry, developmentally compromised children such as mental retardation and Down syndrome, cerebral palsy, psychobehavioral disorders such as autism, convulsive disorders, hearing impaired, vision impaired, learning disabilities, followed by conclusion and references. As it is correctly said that don't let disability keep the dentist away. The parents as well as the dentist both are very anxious. The parents because they are anxious whether the dentist will be able to treat such a child, and the dentist on the other hand, because these patients are not coming very regularly, are a little fearful whether it would be feasible to treat such patients in the dental operatory. So let's see what is the definition of handicapped individual. One who over an appreciable time is prevented by a physical or mental condition from full participation in the normal activities of his age group, including those of social, recreational, educational and vocational nature. A child who cannot within limits play, learn, work or do things other children of his age can do. He is hindered in achieving his full physical, mental and social potentialities. While a disabled child is one who has a mental, physical or social condition that prevents the child from achieving full potential when compared to other children of the same age group. It originates before an individual attains 18 years of age, has continued or can be expected to continue indefinitely, and constitutes a substantial handicap to such individuals. Now, the reasons for lack of availability of care for such patients is lack of knowledge on the part of a dentist. Dentists consider themselves inadequate to treat these patients. This could be probably the skill or the infrastructure of the clinic, which probably is a difficult situation to cater to these patients. The other problems such as fear, anxiety and feelings regarding the handicapped child. Now, special dental operatory for special child is basically the same operatory that we work in, but with a slight modification so that we can accommodate if a child like this visits to the dental operatory. The doorway should be 4 inches wider than normal. Flooring should be flat, firm. It should have firm carpets, because when a child such as this will come to the clinic, the child probably cannot walk normally and hence he should not stumble down. And also there is a wheelchair which will come along with the patient, and hence the clinic should be able to accommodate the wheelchair. Wheelchair turning space, for example, if we need to treat the patient on the wheelchair itself, and a movable dental chair, because so that we can move the dental chair and accommodate the space for the wheelchair. Adjustable dental chair to match different wheelchair designs. So this is a diagram which shows what is basically the changes or modifications that we require in a dental operatory. So we should have a straight axis, probably a portable dental chair which can be moved apart if the child has to be treated on a wheelchair, or the space, a little more space so that to accommodate the movement of the wheelchair. Now, there are 3 programs that have been proposed by Bensberg to teach oral hygiene to these children. So these children are self-care group, the partial care group and the total care group. The self-care group is the easiest to deal with. They require minimal supervision. Children who can maintain excellent oral hygiene. Modification is rheumatoid arthritis or patients with chronic joint damage. Modification of toothbrush handle will be required for such children, and they attend special academic schools. The partial care group is a moderately disabled group. They require close supervision. Motivation is difficult because probably there is some language communication difference. They do not expect rapid learning. Break tasks into small, easy steps. So rather than telling them that if they brush properly, they will have a better oral hygiene and it will keep the caries away, it is better to break these into small, that you have to brush 2 times a day. So it becomes easier for these children to comprehend the instructions. And positive reinforcement is required. The total care group, these are the severely disabled and are generally confined to the wheelchairs. Individual assistance is needed, and power toothbrush would be best for these children because they would not have the comprehension to hold the toothbrush to brush properly. Patient positioning. Proper position of the child and person performing oral hygiene is crucial. So the various positions include standing position, patient in wheelchair, on bed or sofa. For uncooperative patients, we will require someone who will restrain hands or legs of these children. For patients unable or unwilling to open the mouth, so you require mouth props or other modifications that will keep the mouth open for oral hygiene maintenance. Treatment immobilization. A patient who requires treatment but cannot cooperate due to lack of maturity, cannot cooperate due to lack of mental or physical disability, does not cooperate after all behavior management techniques have failed, and when the safety of the patient and the operator is at risk without the protective use of immobilization. So we basically need to immobilize the patient so that it does not, the sudden jerky movements of the patient cause any damage to the patient himself or the operator, or might put the operator at risk. The various immobilization aids include those for body, hands, head, etc. So for body, it is Pappus board, triangular sheet which was proposed by Meg. So this triangular sheet is basically tied around the chest, so there is limited mobility of the patient. Pedi wrap. So once the child is placed on a dental chair, it has got a small modification. It is the child is completely wrapped like a blanket, so there is no movement of the hands, legs or the various body parts. Beanbag. This is more comfortable for a child who's got cerebral palsy because sudden jerky movements of the chair might aggravate or frighten the child. So the child can be treated on a beanbag. Safety belts and extra assistant. For extremities, we will need posy straps. So these are basically straps which we tie around the hand of the patient and tie it to the dental chair so that the patient cannot suddenly move the hands and might cause some trauma. Velcro straps, towel tapes and extra assistant. For head, we will require forearm and the body support. Head positioner, which will position the head in a particular area, the plastic bowl and the extra assistant. Intraoral, we require padded tongue blade. So it is basically a long instrument, a spatula for example, on which we can tie a gauze piece so that the spatula itself does not cause any damage or trauma to the gums or teeth, and it is the spatula will be completely tied with a band-aid or a gauze piece, and this can be used intraorally to open the mouth. Molt mouth props, Ferguson mouth props, towel. These are the mouth props that we generally use. Now there is a changing trend which we've seen maybe around 20-25 years back and to what the dental scenario is today. We've got more advanced technology for these patients and probably less invasive procedures for these patients, in which the purpose of preventive or arresting caries at an earlier level can also be maintained. On the other hand, the management of this patient as a whole with either general anesthesia or nitrous oxide anesthesia options are also available. So let's start with mental retardation. It is the most common and the definition is significantly sub-average general intellectual functioning which originates during the developmental period and is associated with impairment in the adaptive behavior. Now let's see what these three colors which I have marked, what do they mean individually. So significantly sub-average general intellectual functioning is developmental or intelligence quotient that is below 70 and represents 2 or more standard deviations. It originates during the developmental period, is defined as within the limit of 18 years of age. So mental retardation suddenly cannot develop after 18 years of age. It is basically during the period of developmental stages when we see these changes. Adaptive behavior, adaptation, as can be seen that a child can adapt to a particular situation. So individuals' effectiveness in adapting to natural and social demands of environment, that is maturation, learning and social adjustment, is slightly less in these individuals. So diagnosis of mental retardation is not based on IQ alone, but there are various factors that when it develops, and the adaptive behavior of the child, the emotional quotient, the intelligence quotient, all these factors together, when they come into a particular criteria, the child can be termed as mentally retarded. So the formula for computing intelligence quotient is ratio between mental age and chronological age. So IQ is equal to MA, that is mental age, divided by the chronologic age, multiplied by 100. So according to AMD, the IQ scores and its functional level, they have correlated. A child who is having 69 to 55 IQ score is mildly or adequately retarded. 54 to 40 is moderately retarded. 39 to 25 is severely retarded, and below 25 IQ score are profoundly retarded. So now if we see the degree of mental disability, that is a mild, which has got a IQ score of 67 to 52. The communication with these children is they are able to speak for most communication needs. So probably they will be able to tell if they want food, water or anything. They've got pain in a tooth, they will be able to express that. A child who is moderately disabled will have a IQ between 51 to 36. These are basically the different scales that are used to measure the intelligence or the IQ quotient. So they communicate at basic level with others, and severely or profound have 38 and below IQ level, and they might not speak, might not communicate, so will not be able to find out that this tooth is painful or the child has got some other problem in the oral cavity. So mute communication in grunts, they will make different kinds of noises, or little or no communication skills at all. The etiology of mental retardation is genetic diseases, maternal fetal infections, connectitis, cretinism or fetal alcohol syndrome. The natal include birth injuries, infections, cerebral trauma, hypoglycemia, hypoxia. Postnatal would be cerebral infection, cerebral trauma, poisoning, cerebral vascular accidents or severe malnutrition. The anomalies of dentition in these children are most common as dental caries. Probably because they are unable to clean the oral cavity, they would probably not open the mouth for the parents also to maintain a good oral hygiene. In older children, periodontal conditions, hypocalcification of teeth and malocclusions. So the dental consideration, we should have a thorough medical history that the patient does not have any underlying disorder, and hence we need to take proper precautions. These children will have a very short attention span, they would be restless and hyperactive. They should be given a brief tour of the office so that they get acclimatized to the situation and might behave in a better situation for the dental treatment. Be repetitive, speak slowly and in simple terms, listen to the patient, be sensitive to the gestures and verbal requests. For example, these patients might not be able to verbally express what they need, but they might have some gestures or the movements, the sign language, which might help us point out to a particular thing that the child wants or is trying to say. Alternative form of communication, so probably there is a probability that these child might be writing in a notebook, they might write certain words to express their feelings, so they must be allowed to get their notebooks or diaries to the dental operatory. One instruction at a time because the comprehension skills of these patients are less. Short appointments and appointments generally in the morning when the dentist as well as the child have got good energy levels and probably would be able to communicate or be in a better situation for the dental treatment. Emphasis on good oral hygiene should be given because invasive dental treatment in these patients might become difficult. Patience and sensitivity on part of dentist is required. Gentle firmness. Behavior management will include tell, show, do. So we can slowly and with one step at a time, we can tell them what we are going to do, show them the various instruments, the water coming out of the aerator, and then start doing the treatment. In severe cases, sedation and general anesthesia can be used. Next is Down syndrome. It is the most common chromosomal aberration. First description of characteristics was given by Esquivel in 1838. The chromosomal abnormalities include extra chromosome 21. It is also known as trisomy 21. Translocation is seen in 3% and mosaicism or partial trisomy in 2% of the cases. There is 1 in 600 to 1000 live birth and it is known to increase with the increase in maternal age. Now let's see the various physical features. Head, prominence of forehead and flattening of the occiput, that is the back region of the head. Eyes, hypoplasia of iris stroma and brush-field spot that can be seen inside the eyes. Face is round, flat face, flat nasal bridge and upward slanting palpebrae fissures. So these are the very characteristic features of Down syndrome, and probably before you get a diagnostic result, the facial features itself is a very confirmatory diagnosis for Down syndrome. The limbs are short and broad, clinodictally of fifth finger. Wide space between the first and the second toe. Transferred palmar semen crease. So here we can see they have a very characteristic feature of a semen crease. You will be able to see only one line in the palm and this is known as transverse palmar crease or semen crease. The systemic anomalies include congenital cardiac anomalies that is seen in 40% of the patients, increased susceptibility to infections, greater risk of developing leukemia, although this is only in the initial stages, and as the child grows, the risk of developing leukemia decreases. Increased laxity of transverse ligament between atlas and odontoid process of cervical vertebrae. So we have to be very careful when we place these patients on the dental chair, and sudden movement of the neck might trigger any factor for these patients. Motor function is delayed. Behavior is warmth. These patients are generally warm, gentle, patient, tolerant and complete honesty is seen with these children. Speech, expressive language could be delayed. Oral anomalies include stair palate, that is they've got a very steep palate. Hypotonia of perioral muscles and angle of mouth could be pulled down. Hypotonia of the lower lip, mouth appears open due to relatively enlarged tongue. Tongue is scalloped or crenated. Pseudo class 3 malocclusion can be seen in these children. Dental anomalies include microdontia, that is small teeth, hypoplasia, partial anodontia, taurodontism, low prevalence of dental caries in these children, bruxism, delayed eruption of teeth, but there is a rapid generalized periodontal breakdown in patients with Down syndrome, anterior and posterior crossbite. Now, how do you manage these children? These children are generally cooperative, cheerful, affectionate and well behaved. So, dental procedures can be provided without any compromise. Preventive dental care or home care oral hygiene should be stressed for these children. Sedation is difficult because of obstructed nasal passage. Immobilization and general anesthesia can be used in severe cases when you have patients with Down syndrome and who as well are mentally retarded. Cerebral palsy. Nelson et al. Described it as a group of non-progressive disorders resulting from malfunction of motor centers and pathways of brain. It may occur in conjunction with speech defects, mental retardation, visual defects, seizures, deafness, and behavioral and emotional disorders. The causes of cerebral palsy include any process that reduces supply of oxygen to the developing brain, could be cord strangulation, hemorrhage, infections, or birth trauma. It has high association with prematurity, so there is a higher probability that the premature child might be born with cerebral palsy. Classification. Cerebral palsy can be classified as spasticity, athetosis, tremors, rigidity, ataxia, or multiple symptoms. These are basically classified on the symptoms that we see in children and a particular area of the brain that is affected. So spasticity, it is the lesion in cerebral cortex. Hypotonia of muscles, that is stiff and awkward movements. Hand and arm are flexed and held against the trunk. Foot and leg are rotated internally, and thus foot and leg, these we can see they are rotated internally, and hence they have a limping gait. Head roll, difficulty in maintaining posture, impaired chewing and swallowing. Speech defects, inability to control voluntary movements. Athetosis, lesion in basal ganglia, they have got slow breathing involuntary movement which is known as athetosis. Quick jerky movement, that is chorioathetosis. No spasticity or weakness of muscle is seen. Involvement of neck musculature leads to hypertonicity. Severe bruxism, hypotonicity of the perioral muscles, and hence they have got excessive drooling. Chewing, swallowing and speech difficulties can be seen, and all four extremities are involved. The next is ataxia. This is the lesion in cerebellum, inability of involved muscles to contract completely, difficulty in grasping the objects. They will have a stumbling gait, tremors may be present, and no muscular involvement. Rigidity, as the name suggests, they will have rigid or stiffness in the various body parts or the muscles. It is the lesion in basal ganglion, stiffness and constant rigidity, voluntary movement which are slow and stiff. Tremors are repetitive, rhythmic, involuntary contractions. Mixed could be a combination of any of these various various types of cerebral palsy. These can affect the following areas: monoplegia, that is only one extremity will be affected. Diplegia, affecting both the legs with minimal involvement of the arms. Paraplegia, involving of both legs. Hemiplegia is involvement of one side of the body, and quadriplegia is all four limbs are affected. Orodental characteristics associated with cerebral palsy are: no specific oral disease is related to cerebral palsy. So basically you will see spastic, they will have class 2 division 2 malocclusion, which otherwise can also be seen in normal children. They can have crossbite, tongue thrust, shutdown or introvert. They could be fearful, environment devoid of excitement for these children, because sudden movements can cause frightening of these children and they might not cooperate. They are afraid of demonstration of affection, slow to show anger. Athetoid will also have class 2 division 1 malocclusion. They demonstrate little fear, readily provoke to outbursts of anger, and enjoy company and engage in conversations. Ataxic may have ankyloglossia, as is seen in some cases. They have little fear, anger is readily provoked, they make friends, seek affection. Trauma is common in these children because they've got class 2 malocclusion. Periodontal disease is common. Pouching of food, so they've got a habit of keeping the food in the oral cavity for a very long period of time. Rumination, that is they will keep chewing the food throughout the food, the same food is eaten again, and they will keep chewing, pouching the food in the oral cavity. Pica is putting things which are not required, unnecessary things that the child might eat. Now there are certain reflexes that are generally seen in infants in the neonatal period. but these reflexes are also carried forwarded in patients such as cerebral palsy. So these reflexes include asymmetric tonic neck reflex. So head suddenly turned on one side, hand and leg of that side extend and get stiffened. So one has to be very careful when we are trying to manipulate the head or tell the patient to turn the head on one side during treatment. Tonic labyrinthine reflex, if head suddenly falls backward while the patient is lying down, the back may assume position that is known as postural. Startle reflex, sudden involuntary and forceful movements occur when the patient is surprised by stimuli or unexpected movements by the other people. So suddenly if we are doing the chair up or down, the patient might get very frightened, and we can see sudden involuntary forceful movements which might frighten the patient. Dental management, treat patient in the wheelchair if required, place and maintain patient in the midline of the chair so that the patient might not fall. Keep back slightly elevated, use of mouth props, prevent abrupt movements, introduce intraoral stimuli slowly, minimize patient time in chair, use of restraints for these patients. The next is autism. It is an incapacitating disturbance of mental and emotional development that causes problems in learning, communicating, and relating to others. The synonyms of autism include Canis syndrome, early infantile autism, infantile psychosis, childhood schizophrenia. The IQ score in these children is generally below 50. Etiology is unknown, and it is known by some that it occurs in children of highly intellectual parents. The behavioral characteristics are extreme aloneness. They do not want to play with other children. They will sit aloof, play with their own toys. Language disturbance, they speak very less, or mutism. Repetitive speech, that is echolalia. They will keep repeating the same word again and again. For example, if they want a ball, they will keep saying ball, ball, ball. Difficulty with concept of yes. Desire to maintain consistency. So for example, if their basket of toys is kept in the room on the left side of the bed, they would prefer that the basket is kept on the left side only. If the position of the basket is changed, there are some changes in the child might get angry, the child might throw tantrums, although they are able to speak less. They intrigue with spinning objects, so rather than connecting to the humans, they are more connected to the non-living things. Eating disturbances, hyperactivity, nystagmus, and mental retardation. They display anger and affection on the toys. So as I've already told, rather than connecting to an individual, they are more connected to the toys or the non-living things. Management, several dental visits to acclimatize to the dental environment. So they might require many visits to get used to the dental operatory, to get used to that this is a safe place, they can come here. Use of positive reinforcement, patience, and slow approach. They may be allowed to bring some comfort items to the clinic because they do not want any change. So probably if they have a toy which they keep carrying throughout the house, the child might also be allowed to get that to the dental operatory so that the child feels safe. Sedation and general anesthesia can be carried out after all the anesthetic protocols are followed. Special education programs for family and family counseling. The next is convulsive disorders. It is a sign of abnormal brain function. Etiology is idiopathic, symptomatic. It could be febrile seizures, partial seizures, generalized convulsions, that is the various form of epilepsy that we see, grand mal, petit mal, or the focal seizures. Self-induced seizures. Now how do we prevent these seizures in the dental office? Reducing stress. Stress could be a triggering factor to initiate any of these seizures. Do not place light directly on the face, because the sudden light on the face or the blinking of the eyes might lead to these seizures. Avoidance of seizure promoting drugs. Daily medication routine should be followed before the dental treatment, and adequate preparation of the patient before the treatment is started so as to reduce stress should be done. Use of mouth props, because sudden closure of the mouth, the occlusion is so tight that it will be difficult to remove the fingers while doing the treatment. So mouth props should be used in these patients. So if a child develops seizure in the dental office, we should maintain a patent airway. So if you were doing any treatment, anything that is there inside the mouth should be removed, so that to avoid the risk of aspiration. Dental instrument should be moved away from the patient. Patient is placed on the floor, and use of restraints. Discontinue the treatment. The next we'll see is hearing impairment. Boley and Gardner have described 4 levels of deafness, that is mild hearing loss 15 to 30 decibels. They are hard of hearing, partial hearing loss, they require a hearing aid. Severe hearing loss more than 70 decibels, difficulty in learning language because they cannot hear, they cannot comprehend and thus reciprocate or mimic the topic. Profound hearing loss is more than 95 decibels, lip reading, sign language and manual methods. Incidence is 1 in 600. Etiology could be rubella, influenza, ototoxic drugs, birth injury, erythroblastis fetalis, mumps, chickenpox, polio and injuries. So how do we manage a patient who's got a hearing loss in the dental clinic? The patient who's got minimum hearing loss, there could be misunderstanding of the instructions. So the parent might tell us that the child can hear partially, and when we give the instruction, the child might hear something else which we have not said, and hence create a miscommunication. So we have to decide the mode of communication. So probably if the patient cannot hear, we can write the things on a piece of paper and give it to the child to read, or the sign language can be used to explain it to the child. Use of chalkboard or writing pads. Parent should be visible to the child to reduce the anxiety levels. We should face the patient and speak slowly. We should give one instruction at a time so that the patient can understand what we are saying. Watch for patient's expressions. So once we are doing that, once we get used to teaching these cases, we will understand by their facial expressions whether they have understood what we have said or they have not understood. Tell, show, feel, do approach. So where we do only tell, show, do for these patients where probably they will not be here, so tell components become partially unacceptable. So we can let the child feel the various instruments, or how we are going to do the water from the air rotor, the child can feel on his hand and then start doing the treatment. Adjust the hearing aid, because if the child is wearing a hearing aid, the sound of the air rotor might be multiplied to what the child is hearing in his ears. So the sound part of the hearing aid should be modified. Non-verbal communication can be used, and reassurance, keep patting the child that the child is performing well and how he is reciprocating to the treatment. Vision impairment. So it is not an all or nothing phenomena. Visual acuity less than 20 by 200. So if it is more by 20 by 200, visual field that is less than 20 degree. Causes could be optic atrophy, cataract, syphilis, rubella, hypertension, diabetes mellitus, trauma. So dental problems are prolonged immature swallowing, prolonged use of bottle in these children, poor oral hygiene, hypoplastic teeth, traumatic injuries, gingival inflammation, and hence parental counseling is required. That is the preventive measures that need to be taken at home to prevent these conditions from occurring. Management. We should be aware of what is the duration of blindness. Guide him to the dental operatory. So if the child is unable to see, somebody or the dentist himself or the receptionist can guide by holding the child's hand. We can describe how the clinic is looking, what posters do you have, what is the color, where is the chair, how the child has to sit. Allow patient to ask questions, and rather than tell, show, do, we will have touch, taste and smell. So a child who cannot see, the child can touch, he can smell the various materials that you're going to use, taste, probably if we can give them to taste something, use of audio cassettes and braille so that they understand the instructions. Distraction and loud noise should be minimum. Patient should not be left alone because the child is not aware what things are kept in the surrounding. The child is not used to the dental laboratory, so not even for a second the child should be left alone on the dental chair. Learning disabilities. Learning disabilities apply to children who exhibit disorder in one or more of basic psychological processes involved in understanding or using spoken or written language. So it is seen more in boys than girls. 3 out of every 100 children will have this. Cause could be minimal brain injury, damage to central nervous system or a genetic factor. Clinical features could be delayed milestone, behavioral disorders, decreased logical thinking, lack of language skills. Communicating with people who have learning disabilities is difficult because they could be visual or hearing impaired, poor memory, difficulty in sustaining attention. So it could be difficult for these children to accept dental care. Patients have preferred method of communicating could be speech, which is slow, clear. Patient should be given plenty of time to respond. So it should not happen that we said open your mouth, then we'll use a micromotor, air rotor, and then we will remove the caries and then the treatment is done. So what would the other way would be that we have to say you have to open the mouth, keep the mouth open till I give you further instructions, and then explain part by part what treatment, how you're going to do the treatment, what you are going to use, so that the comprehension on the side of the patient becomes easier. Appropriate body posture and eye contact should be maintained. Muscular dystrophy, it affects neuromuscular and skeletal system. Skeletal muscles could be affected, more common in males and females, and the oral manifestations are flaccid, weak perioral muscles, expanded arches, malocclusion, and inability to adjust to removable prosthodontic appliances because the retention will be difficult, and also because of the continuous muscular dystrophy the appliance does not stay in place. Drugs that depress respiration and general anesthetics should not be used or should be used with utmost caution because relaxation of the respiratory muscles might lead the patient to difficulty in respiration. So with this we finish this part. Thank you for a patient hearing.